So many of you have likely written about community health workers. You will find us here in the United States working around community violence prevention in emergency department facilities. You may find us helping new immigrants and refugees navigate new health systems and eligibility programs. You may find us conducting home visits or working with families to ensure immunizations or oral health. You can always find us at our state and local governments lifting up legislation and amplifying our roles. As the APHA has acknowledged CHWs as frontline public health workers, we have deep cultural origins that obviously extend as diverse as the United States is throughout the world, with deep sort of cultural experience, health beliefs, and religious practices around health, as well as shared experiences that are born and sort of tested here in the United States. Community health workers are those who have a calling for compassionate service. We accompany, we walk alongside, we partner with, and engender trust with our community members. We often live in the community, or we are peers with the same lived experience. We are HIV positive, we are living with chronic disease, we are cancer survivors, we are from the reentry community, we were once migrant health workers, etc. And to that end, we conduct a range of roles and skills and competencies that allow us to pursue improvement of whole health well-being. We are disproportionately female and females of color. We are often peers and survivors of many of the barriers to the social determinants of health or social drivers of well-being that many marginalized communities experience. Oftentimes, our funding reinforces this reality. CHWs often work in short-term grant or project-based funding. We are among the lowest paid out of all public health frontline workers. And often we are focused in programs and interventions that are reflective of and in fact are sort of impacted by the marginalization, the sort of siloed sectors that are persistent throughout the United States, and the historic sort of structural racism that has embedded itself throughout our systems and policies. We work in under-resourced communities often in a variety of different settings and across every sector. So you will find us as liaisons in education. You will find us working on the opioid epidemic. You will find us working upstream around housing and immigration, workforce development, as well as working in hospital systems and with primary care providers. We are bridge builders. We are navigators. We are health educators, but we are also community organizers and researchers and advocates. In the early months of the pandemic, many CHWs were actually being laid off or furloughed. Instead of public and private institutions and employers recognizing this critical frontline infrastructure workforce and the opportunity that it provided to engage deeply and authentically with community, a lot of our grant programs and our services were disrupted. And so NACHWA launched a national campaign to say that CHWs have a profound and urgent role to strengthen public health response during COVID-19. I hope that some of the tens of millions or even billions of dollars coming through the federal government will be invested in community health worker-centered and led organizations so that we can come through and out of this pandemic with enhanced capacity, not reduced capacity. There are ways in which we can ensure and advocate for increased and enhanced language access around testing and contact tracing and social care needs. The way in which the data that many CHWs collect needs to be disaggregated and analyzed so that we can dig deep into inequities in testing, inequities in contact tracing, and the ways in which CHWs can confront and dispel myths and racial discrimination that we're finding during this pandemic. Many community health representatives that are trying to address chronic disease, housing, immunization, or others go home to dwellings without running water or electricity. These are frontline public health workers who are attempting to respond to the pandemic while they themselves are yet under resourced. We do not have a vaccine now. And so we have time if public and private institutions will be authentic and will invest in real conversations and real community engagement to begin to not repair all of the trust, because I think that is a lengthy endeavor, but certainly to center trusted messengers and trusted organizations to begin to build bridges so that everyone who believes in the efficacy of the vaccine is available to have it if they need it. The vast majority of CHWs do not work out of health systems. The vast majority of them work through community-based organizations, and that puts them at greater risk because CBOs also often don't have the type of resource to get PPE, to get that sort of training, and to have sort of hazard pay and protections to allow CHWs to continue their on-the-ground work. There have been a number of different pieces of legislation that have been offered through the Senate and to a lesser degree through the House that include CHWs. But again, this is a sort of short-term funding around contact tracing and nothing sustainable. Context of the Navajo Nation, because if some of you were tracking the funding, you will know that up until June 2020, much of the funding that we saw across the country, the $1 billion here, the 2 billion, the 1.5, 500 million that was distributed through the states. If you went to the CDC website and looked at the tribal nations up until June, they had not received a penny. They had not received 1 penny to address the testing and contact tracing. Members of the Navajo Nation were asking people to send them masks so that they could do their frontline work of contact tracing and testing. So it's really a shame. And I hope, again, that more of these stories will be lifted up.